Assalamu alaikum. We quickly move to our second session, that is the interventional pharmacology and precision PCI. I would like to invite the chairpersons, Professor Shehzad Tawab, Dr. Khurshid Hassan, Dr. Asad Salim, Dr. Nasir Ali, Professor Wajid Ali Khan Faisal, Dr. Fazlur Rahman, Dr. Asma Shabir, and Dr. Hamza Ghori. I am Dr. Rehan Riaz. I am working as Assistant Professor Cardiology at Faisal Institute of Cardiology. I am moderator for the next session. We are already 20 minutes late. We are trying to compensate this, and I'll request every speaker to get 9 minutes for the talk so that we can end up session in a timely manner. So quickly moving to our first speaker, Mr. Faraz Farooq. He is Assistant Professor Cardiology at NICVD, and he'll talk about Cath lab pharmacology.
Bismillahir Rahmanir Rahim. My name is Faraz Farooq Memon, and I'm working as an assistant professor at NICVD Hyderabad. So today's my talk is going to be on Cath lab pharmacology. It's very difficult to handle two things together. So the different classes of drugs which we use in Cath lab are sedatives and analgesics, vasodilators. Then we use contrast media, anticoagulants, antiplatelet agents, vasopressors, inotropes, and antiarrhythmics. So we'll start, we'll take one by one. So we'll talk about sedatives. We all have been using these sedatives, like we use midazolam and fentanyl, and the duration of action of midazolam is from 15 minutes to 80 minutes, and the duration of action of fentanyl is 30 to 60 minutes. Now, what can go wrong with these sedatives? It can cause respiratory failure because excessive sedation may suppress respiratory drive. How can we prevent that? Avoid excessive sedation, monitor oxygen saturation throughout the procedure, and if it occurs, respiratory failure occurs, flumazenil for reversing midazolam and naloxone for reversing opioids can be used. Intubation may be required for severe respiratory depression. Delayed response to oral P2Y12 inhibitors can be caused by delayed emptying of the stomach. So when we use opioids, analgesics, we might not get appropriate response of P2Y12 inhibitors. So next are the vasodilators. There are two types of vasodilators, small vessel vasodilators that are nitroglycerin, and large vessel dilator, that is nitroglycerin, and small vessel dilator, that is nicardipine, nitroprusside, and adenosine. So nitroglycerin, we use them for dilating the coronary arteries, treat hypertension, and treat pulmonary edema. And we use them intracoronary and intragraft about 100 to 300 micrograms. What can be the problem with nitroglycerin? It can cause hypotension because it decreases preload, it decreases afterload, and the problem with this drug, the phosphodiesterase type 5 inhibitors like sildenafil, tadalafil, the co-administration of nitroglycerin can cause life-threatening hypotension. Then if somebody is having hypertrophic obstructive cardiomyopathy, nitroglycerin worsens left ventricular outflow obstruction by decreasing both preload and afterload. So how to prevent hypotension? Avoid using multiple doses of nitroglycerin. Do not administer in patients with hypotension or patients with right ventricular infarction. Do not administer in patients who have recently received phosphodiesterase 5 inhibitors, and do not administer to patients with hypertrophic obstructive cardiomyopathy. If hypotension occurs, do not administer additional dose of nitroglycerin, administer normal saline, and waiting would solve the problem because hypotension often resolves after a few minutes. Administer vasopressin if required, and if hypotension persists, then you have to assess for any other potential cause like bleeding. Nitroglycerin also causes headache, flushing, dizziness, and tachycardia. The next drug is nicardipine. It prevents and helps us treat no reflow, and the intracoronary dose is 100 to 300 microgram. And what can go wrong with this? Same as nitroglycerin, it can cause hypotension. Again, nitroprusside is also used to prevent and treat no reflow. Intracoronary dose is 100 to 300 microgram, and it can also cause hypotension. Verapamil additionally helps us in prevent radial spasm. It also helps us in preventing and treating no reflow, and it can also cause hypotension. The other drug is adenosine. It prevents and treats no reflow, cause dilatation during physiologic testing like FFR. And what can go wrong with this adenosine is it can cause heart block, and this is most likely to occur with injection in the right coronary. So how to prevent this complication of heart block with adenosine? Avoid high doses of adenosine in the right coronary artery. So how to treat if a patient develops AV block with adenosine? Watchful waiting can help. Adenosine has a shorter half-life, so it will go away. The atrial fibrillation is the most commonly documented adenosine-induced arrhythmias in about 2.7% after intravenous administration, and is usually well tolerated except in patients with accessory pathways. So we'll move quickly because we've got a lot of slides. Treatment for atrial fibrillation, if it is developed, we can give DC cardioversion. And if DC cardioversion is not desired, we can use imidrone and use AV blocking agents like beta blockers and calcium channel blockers. Then adenosine can also cause ventricular fibrillation. It can cause torsade or ventricular fibrillation and can be triggered by adenosine administration, usually after a ventricular pause and due to R on T phenomena, but may also occur without a pause. So ask the patient to cough. Coughing, as forceful coughing, could generate sufficient blood flow to the brain to maintain consciousness until definitive treatment, which is defibrillation. Next, yeah. So this is a pictorial here. They've introduced adenosine, and then we see a block, and then patient reverts, and there is R and T phenomena, and patient develops VFib. So we also use definitely contrast media, which helps us in visualizing the coronaries and peripheral arteries. It also clears blood from the coronary artery to perform OCT. Isoosmolar contrast media have been associated with lower risk of contrast-induced nephropathy. Contrast can also give us allergic reactions and can occur immediately after administration or can be delayed, usually 6 to 12 hours after contrast administration, and can range in severity from mild skin rash to life-threatening angioedema and anaphylactic shock. It is caused by IgE-mediated reactions or direct mast cell degranulation. So how to prevent this? We should use isoosmolar contrast media, and if for patients who already had allergic reaction to contrast administration, we can administer steroids, diphenhydramine, and cimetidine. So prevention, if a patient needs emergency coronary angiography or PCI, hydrocortisone can also be used, 100 milligram, to go ahead with the procedure. Then this contrast can also lead to thyroid dysfunction. Iodine administration to patients with underlying thyroid disease may lead to hypersecretion of thyroid hormones, a phenomena known as Jod-Basedow effect, usually occurs 2 to 12 weeks after iodine administration. Next are the anticoagulants. They prevent thrombus formation within the coronary arteries or within equipment inserted into the body, reduce the risk of radial artery occlusion as well. So the dose, we all know that it is 70 to 100 units per kilogram if the GPI or cangrelor is not given. And if GPI and cangrelor are given, then the dose is 50 to 70 units per kilogram. Monitoring is preferred by checking the ACT every 20 to 30 minutes. And for hemochrome device, 300 to 350 seconds are recommended, and for hemotech devices, 250 to 300 seconds ACT is recommended. Now, if you have to reverse, heparin can be reversed with protamine, and protamine can cause severe systemic hypotension and relative pulmonary hypertension due to constriction of pulmonary vasculature. And stopped. Thank you very much.